patient's wearing any type of a necklace or whatever, make sure they take it off, or some kind of a chain or so on. When you're motion palpating, again, the patient's going to shrug their shoulders, put a tight retract. Up, down, forward, back, so on. The side that is a problem, of course, is the history, your motion palpation, static palpation, tenderness, swelling, all that stuff. Contact points, just right here on the proximal border of that, stabilizing the scapula from behind. You're just going to come in, make the adjustment. It's a female, you have to cup the breast. Okay, don't forget. It may need torque, and if you torque it, how are my fingers going to go, up or down? Up. This way. Okay, because that will knock that one. If it's gone straight posterior here, the only thing you're going to do is bring this up, right, at your elbow. There you go. And now what am I going to do? Extend. That's all I'm going to do. Okay? If I have a problem at the AC joint, I'm just going to find the AC joint, stabilize this, and I'm just going to push down here. Okay, it should feel a nice springy down and back motion. It should be equal side to side. If you feel that this is a problem with the patient, not totally dislocated, but it's just not moving quite right, you just bring this up, basically the same move as you did for the posterior clavicle at the SC joint, except instead of extending, what are we going to do? Externally rotate. Holding this in place, externally rotate. Okay. Glenohumeral joint, just motion it. Feel the joint move back and forth. If you're going to adjust this, you're going to take the patient's arm like this, bring it around a couple times, get it happy to move back home. Bring it over here. Hold this in place here. Then what you're going to do, if it's a female that have to cup their breast, you're going to put your body behind there, stabilizing the scapula. You want to keep the patient's hand supinated and just bring your force up this way. Okay? If it's the scapulo-costal joint, have the patient raise their arms up over their head as you're putting your phenars right here on that border, inferior medial border, feeling it move up and down, right? And they should slide out nice and evenly. If it's not moving, then you're going to put the patient on their side. Ready to get that on video? Okay, you have to face me.
That would make sense.
Don't. Okay, so if it's gone fixated in the medial position, you're going to have to bring that patient, come a little closer to me. Roll that patient over, contact here, and as you roll them over, you're going to thrust it back towards you this way, and you're going to torque it, just like this. Right? If it's gone lateral, you correct it like this. Just bring this up. Bring it up straighter and take it down. Or you can reach under here if you can't get a hold of it. Okay. To test that, you have the head face down. To test that, you just have the patient's arms at their side. And you're just going to motion palpate with your phenars on the inferior lateral border, motioning them, taking them from lateral to medial. Any questions about anything with the shoulder? I'll have you stand up. If you have problems at the elbow and you think it's the ulnar humeral joint, you're going to motion it this way. Remember, keep the hands supinated when you're doing this. And grab it this way, not like this. Grab it like this. Motion. Compare the good side to the bad side. The bad side will have that spongy end feel. The good side will have like a bony lock. When you're going to adjust it, you can use your thenar. You can use a marble shooter's grip. You can use this. I'm not sure what it's called. Right? A lot of different ways to do this. Take your slack out, And remember, don't do this, right? It's not a slot machine. You just straight up take out your slack, rest it up. And, if you have trouble with the radial joint, just gonna rotate it back and forth. This will be a marble shooter's grip here, contact right here, stand. The patient's arm supinated. You're off to the side and slightly behind the patient. Put your line of drivers coming in P to A and lateral Q. If the humerus, or excuse me, the ulna has gone medial, you can pull it back this way. Or if it's gone lateral, you can add a little bit of that to your thrust. We'll probably just give you straight posterior listings on that. I think that's everything, right? So practice them all. Anything you have trouble with, call Dr.